Good afternoon, everyone. My name is Sarah Fuchs, and I am a senior specialist for the Community Education Department here at the Muscular Dystrophy Association. We're thrilled to have you join us for today's webinar on maintaining a healthy weight. This learning event is a part of our larger MDA community education programs, which focus on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section of mda.org for updates on upcoming events. We are recording today's event and will be posting it to the website for on-demand viewing at a later date. Everyone registered for today's session, whether you attend or not, will receive that information in their inbox a few weeks after this presentation has concluded. Please know that all phone lines have been muted, but you can still ask questions. We'll have a Q&A session at the end of our speaker's presentation. Simply use the chat feature to type in your questions. Feel free to type in your questions and send them in as you think of them, and they'll be addressed at the end of the presentation. For nearly 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through the MDA Care Center Network, and advocating for access and inclusion for the neuromuscular disease community. MDA delivers its mission through research, access to care, advocacy, education, recreation, and engagement. Since its inception, MDA has invested more than $1.1 billion in neuromuscular disease research. Our MDA care centers are located at over 150 top medical institutions nationwide, providing care from clinicians who specialize in neuromuscular disease. MDA's advocacy work focuses on support for accelerated approvals and novel research, access to healthcare, accessible air travel, and more. This focus plays a vital role in shaping laws and policies that support the needs of people living with neuromuscular diseases. Our community education and recreation programs are designed to connect individuals and families. We are committed to building a nurturing environment where our members can share experiences, triumphs, and challenges. Every year, we offer over 40 educational programs, over 20 summer camps, and dozens of other activities, both in person and virtually. If you haven't done so already, we invite you to join the MDA community by registering with us. Registering is free, and we'll have a link in the chat for you to do that. Now it is my pleasure to introduce today's speaker, Laura Watne. Laura is a registered dietitian and board-certified specialist in pediatric nutrition. Laura specializes in medical nutrition therapy for infants, children, adolescents, and young adults with a variety of neuromuscular conditions, including Duchenne muscular dystrophy, congenital muscular dystrophy, congenital myopathy, spinal muscular atrophy, myotonic dystrophy, and Friedreich's ataxia. She has been part of the Children's Hospital of Colorado Neuromuscular Clinic team since 2011. She was a member of the Cure SMA Medical Advisory Council from 2018 to 2023. Her other areas of expertise include spina bifida, spinal cord injury, Rett syndrome, and feeding difficulties in patients who are underweight. Laura, thank you so much for being here today, and I will now turn the time over to you.
Great. Thank you for that nice introduction, and I'm happy to be here with all of you. And with that, I'm just going to jump right in. I just have one disclosure to share here, and that is an MDA grant does fund part of the clinical dietitian position at Children's Hospital Colorado. Today, these are the objectives that we'll be covering. We're going to highlight the importance of weight management in neuromuscular disease. I'm going to provide general principles of healthy weight maintenance. We'll be discussing the unique nutritional needs and challenges in neuromuscular disease, and we'll be reviewing resources and tools for weight management. So let's get started with the importance of weight management in neuromuscular disease. Nutrition impacts every area of your life, growth and development if you're a child, heart health, lung function, bone health, skin health, gastrointestinal function, your muscles, nerves, and mobility, and your brain function. Today, we'll be focusing on how nutrition impacts weight. But as you can see, because everything is interconnected, weight impacts all of these other bodily functions too. So just some general principles. Underweight in neuromuscular disease can lead to some adverse effects like pressure sores and skin breakdown, which increases your risk for infection. It can decrease your bone density. It can cause bowel dysmotility. It can decrease your energy levels and make you less active. On the other hand, overweight in neuromuscular disease may make it harder for you to ambulate or move around, or make it harder for you to transfer yourself from one place to another. Overweight can also put you at risk for other conditions like heart disease and diabetes. Here's some other specific ways that weight and neuromuscular disease are connected. If you have a type of neuromuscular condition that involves heart function, declining heart function can increase your energy needs and cause you to lose weight. Respiratory function and weight are especially closely tied together. If you need to use BiPAP and or cough assist, but you aren't very consistent with that, this can cause you to lose weight. If you have a tracheostomy and a ventilator, you might gain weight too fast without decreases to your dietary intake, because that can actually decrease your energy needs. And if you have low weight, that can make it harder to fight off respiratory infections. Healing from surgery is so important, and both underweight and overweight can increase your risk for complications if you're having a surgery. And mental health can be impacted by both underweight and overweight. Let's go through some basic principles of healthy weight management and weight maintenance. So, what is a healthy weight for someone with neuromuscular disease? This is really a $1 million question. And so let me start by explaining how your healthcare providers look at weight. For babies, kids, and adolescents up to 20 years old, your healthcare providers will use growth charts to determine a healthy weight. So we track weight, height, and weight for length under 2 to 3, or body mass index from 2 to 20. And the abbreviation for body mass index is BMI. There are not specific growth charts for neuromuscular patients, but these standard charts can still be useful because we can still watch the trends that you or your loved one are following on the growth charts. For adults, we use weight and height to calculate body mass index, or BMI. And BMI is a ratio of weight to height. In order to have an accurate BMI measurement, however, you need an accurate height measurement. And as I'm sure many of you know, if you're non-ambulatory, getting an accurate height measurement can be a real challenge, and that can really affect the accuracy of your BMI. So the next $1 million question is, do these standard measurements, apply to people with neuromuscular disease? And my answer is sort of, but not really. In general, I talk to patients about a healthy weight being near the low end of the normal range. People with neuromuscular disease have altered body composition, generally lower than average muscle mass, lower than average bone density, and relatively higher fat stores. And these can all impact, how we interpret BMI. In these growth charts, this is a growth chart for a child under 2. You can see that the weight trend is tracking on the low end of normal. The height trend is also tracking on the low end of normal. Both of these trends over time are following the shape of the curve. So even though these numbers are technically on the lower end, this child is actually growing quite well for having a neuromuscular condition. For adults, a healthy weight might be a BMI near 18.5, which is the low end of normal. But you could have a BMI near 25, and that's technically normal as well. So at the end, I will have some resources for how to calculate you or your child's BMI, but your neuromuscular clinic or your primary care provider should have these numbers for you to look at as well in your medical record. What's the definition of underweight then? For a child, the basic definition is low weight for age when plotted on a growth curve. For an adult, it's technically a BMI below 18.5 kilograms per meter squared. I also want to touch on something, and that's this term malnutrition. The basic definition for malnutrition is an imbalance between your dietary needs and your dietary intake, resulting in inadequate energy, protein, vitamin, or mineral intake that negatively affects growth, development, and other factors. I just want to touch on this because you may see this word in your child's chart or your own chart or your loved one's chart. And I just want to emphasize that it's a medical term. It doesn't feel good when you or your child are diagnosed with malnutrition. But I just want you to know that it has a very specific definition based on trends of weight and dietary intake. And I want you to know that it's not a reflection on poor parenting or poor caregiving for yourself or your loved ones. Malnutrition is typically a direct result of having muscular dystrophy, despite heroic efforts of yourself, of parents, or loved ones providing good nutrition. So sometimes people with neuromuscular disease are underweight and have malnutrition, but sometimes people with neuromuscular disease are just underweight. For neuromuscular patients specifically, I'm looking for a specific and distinct decrease from typical trends. So it doesn't necessarily fit these definitions, but for example, in this growth chart on the left, you can see at approximately between 10 and 12 years old, something specific happened with this patient that really changed the trajectory of their weight that needs to be addressed. So we're just looking, this is an example of how we use the growth chart to look for something that changed and happened and caused some underweight tendencies. What is overweight? For a child, the basic definitions for this is a BMI above the 85th percentile for age is overweight, and a BMI above the 95th percentile for age is obesity. For an adult, overweight is that BMI number between 25 and 30, and obesity is 30 or higher. Again, for neuromuscular patients, I'm not necessarily looking at those specific traditional definitions, but looking for a dramatic increase in typical weight trends. So in this example, you can see something specific changed for this patient around 9 years old that we need to address in clinic. And then just a little question, I'm not sure I have a great answer for, but just to think about, if you have neuromuscular disease and your body composition is different, maybe if you have a BMI in the normal range, does that mean you could potentially be overweight because, like I said, your body composition is different? So There's a lot of questions and concerns around the use of BMI and growth charts and traditional things, but we use them as a basis to look for trends. So one thing I want to emphasize is that for anyone with neuromuscular conditions, stability is good. And that's true for a lot of areas of your health with neuromuscular disease. So weight is a balance of energy in and energy out. And for people with neuromuscular conditions, stability is a very good thing. So for kids, that means stably tracking on growth curve trends. Whether the actual percentile is a little high or a little low is less important. But what is your child? How are they tracking on growth on the growth curve? And for adults, stable weight is good. Even if technically your weight is a little too high or a little too low, having it be stable is a really good thing. So if weight maintenance is balancing energy intake and expenditure, what can we do to help you if your weight is too low? So first of all, it's important to talk to your doctors about things that could be causing excess energy expenditure. And so that could be things like your lung function, your heart function, maybe your child's having a big growth spurt in height. Maybe you've had surgery or an infection, or maybe you have swallowing or feeding difficulties. All these things can increase the amount of energy your body needs. So in these types of situations, we want to increase your calorie intake with food, nutrition shakes, or other medical nutrition supplements, or maybe you need some tube feedings to supplement your intake. There's lots of brands and options to choose from, and we'll get into some specifics of this in a few minutes. And then if you're struggling with any sort of food insecurity, just your team should have a social worker available either at your primary care or your neuromuscular clinic to, help you with resources to access food in your area if you have concerns about that. If your weight is too high, some basic principles would be to try to increase your energy expenditure to the extent that you're able. So everybody's body is different and you have different levels of mobility. So it's really important for you to work individually with your physical therapist to establish safe and appropriate exercise for you. So a lot of patients I work with really loves getting in the pool and swimming. You can have physical therapy in the pool or just swim for fun with your family. And I know there's been some new research for adaptive cycling, especially hand cycling, or this here is a picture of what we call an arm ergometer. This is a tabletop version. I think there's real actual cycles where they're powered with your arms. So there's some really neat options for adaptive exercise, but because I'm not a specialist in exercise, it's very important to talk to your physical therapist about what works for you to get your heart pumping and your body moving as much as you can. If your weight is too high, I really want to emphasize working together. So not singling out that loved one or person in your family who needs to maybe decrease their calorie intake, but working together as a family. So the way we can decrease calorie intake is by eating less. So we call that smaller portions. The types of foods that kind of give the biggest bang for the buck for trying to decrease would be those carbohydrate-rich foods, the carbs, and higher fat foods. One of the, in multidisciplinary clinic, we just have a few minutes sometimes. So we just hit these broad points in clinic oftentimes. One, sometimes people drink a lot of sugary drinks and they drink too many calories. So really looking at what you're drinking. And you can decrease calorie intake by doing less sugary drinks or no sugary drinks. Water is the best source of hydration. When you eat out at restaurants and fast food, you tend to eat more food and more calories. So eating out less often can help you decrease calorie intake. And eating more fruits and vegetables can help you feel full, but those tend to have less calories than other foods, so you can try to eat more of those. These are just some general tips for healthy eating. They apply for anyone, whether you're underweight or overweight, but these are general principles that I cover a lot in clinic. Mealtime structure and routine is very important, whether you need to gain weight or lose weight. So we often talk about this with kids and toddlers and teenagers, but really it applies for anybody. I highly recommend only allowing eating in designated places, of course, with the supportive seating that you need. So for people with neuromuscular conditions, that could be in your wheelchair, or maybe you have a specialized feeding chair. We highly encourage eating at the kitchen counter, at the kitchen table, at your dining table, and really saving those sort of living room TV eating opportunities for special occasions like Broncos games here in Denver, or movies and parties and things like that. I do work with a fair amount of people who really can only eat in their bed. Maybe you have a specialized hospital bed, or your house just isn't conducive for moving around in a big wheelchair. So if that's you and you can only eat in your bed, just try to make that as structured as possible, and having other family members sit with you for meal times, and try not to eat by yourself, because people who follow these tips tend to eat healthier. We recommend turning off all electronic distractions while eating. This can help prevent both under or overeating, and just we really want to encourage enjoying conversation with others during meal times. And then in addition to setting specific places, it's good to have specific structure for times of both meals and snacks. So especially when kids snack throughout the day, we call that grazing, and that can actually work in either direction. It can cause overeating because your child is just eating a lot all the time. It can actually cause undereating because their stomachs always feel a little bit full and they're never really super hungry, so they tend to never sit down and have a really great meal. So all of these basic tips can help with both underweight and overweight. And then again, working together for meal planning and making grocery lists. So maybe it's hard for you to get to the grocery store, but you could certainly help your caregiver or loved one make a list and make sure you're getting the types of foods and meals that you want, and you can help in that process. Now we'll just go through some unique nutritional needs and challenges for people living with neuromuscular disease. I'm going to touch a little bit on calorie and nutrient requirements. We've kind of gone over this, but factors that lower your energy needs can be multiple. Sometimes people with neuromuscular disease tend to be shorter. So just having a smaller body and being shorter decreases your energy needs. We've already touched on the fact that you probably have lower than average muscle mass. So that muscles use a lot of energy, so that decreases your energy needs. If you have good respiratory support and you're wearing your equipment, or you have trach event, that actually decreases your energy needs, which is a good thing. And then just having limited mobility or needing to use a power wheelchair decreases the amount of energy your body needs. Things that can increase your energy needs, again, is that poor respiratory support. If your doctors have told you you should wear BiPAP or have cough assist, and it's just hard for you to make that happen, which is understandable sometimes, that can actually increase your energy needs. Illness and infection increases needs. Healing from surgery, any physical activity that you are able to do increases energy needs. Growing kids have higher needs. Aspiration, which is where if you're eating and drinking and foods and liquids go into your lungs, can actually increase energy needs. We'll talk about that a little bit more. And chewing and swallowing difficulties, those long meal times where it can take upwards of 45 minutes, an hour, 2 hours to eat, you're actually burning more calories than you're getting in some of those instances. It's a little bit tricky to talk about specific calorie and nutrient requirements because they are weight and age dependent and can really vary quite dramatically between people. So it's hard for me to touch on those specifically. But a couple of points, unfortunately, protein supplementation doesn't slow down muscle disease. Your body needs protein from your diet, but unfortunately, your muscle disease is happening inside your cells, and that is controlled by the cells, and the protein that we eat cannot, unfortunately, fix, what's happening in your cells with your muscle disease. We'll get more into detail with this later, but typically you might need a low calorie, low carbohydrate diet, and that naturally, if you're eating well, has relatively higher amounts of protein in it. So I would say, as a general rule of thumb, again, doesn't apply to everyone, but generally I would say people with neuromuscular conditions tend to have lower than average calorie or energy needs compared to non-affected people at the same age and size. So feeding difficulties can really make it hard for someone to eat enough and can contribute to underweight. Poor chewing and swallowing function can result in that aspiration where small amounts of food and liquids might be going into your lungs with eating or drinking. This can also happen with saliva, even if you don't have a food or drink in your mouth. The signs and symptoms of this is coughing, choking, difficulty swallowing, tiredness or fatigue with chewing and drinking. Again, those long meal times, and poor growth or weight loss in and of itself can be a sign of these feeding difficulties. Sometimes these are outright noticeable. Sometimes we call these problems silent, which means they might be happening even though you're not showing signs. So there's some tests we can do to check for these problems. One's called a video fluoroscopic swallow study. And that's where you go to an X-ray room and you get to eat and drink barium, and they take a video X-ray of you swallowing the food and liquid. It's actually a really cool study, but it's just usually a 2 to 3 minute snapshot in time to check if anything's going the wrong way. Another option for this, for checking for aspiration, is called a FEES, or a fiber optic endoscopic evaluation of swallow. This happens at a ENT appointment, an ear, nose, throat doctor appointment, where they put a camera on the end of a tiny tube, and they put the camera in the back of your throat and watch you eat and drink with that, and they can physically see how your swallow is functioning in the appointment. So as a result of having one of these studies, or if you're having outward problems, the solution is perhaps maybe thickened liquids, maybe changing the texture of the foods you eat. Maybe you need some tube feedings as your sole source of nutrition, or to supplement your intake. But I highly recommend feeding therapy, and that can be done with either a speech therapist or an occupational therapist. It just depends on the specialty of the individual therapist, whether they're speech or occupational. But I highly recommend this for all my patients, because it can be very useful to give you tips specific to your issues so you can continue to enjoy eating by mouth. And then I know a lot of patients with muscular dystrophies can have jaw contractures that really interfere with chewing. So I know there's some therapies and therapists that can help you with that as well. So these healthy eating principles we're talking about today can really be achieved no matter what your needs are. So you can achieve healthy eating at any consistency, including tube feedings. So this is a chart of the different thicknesses of foods and liquids that we can modify to help you continue to eat safely by mouth. And really, you can modify most foods to the consistent you need and continue to eat healthy if you're having swallowing problems. You can look for adaptive ways to stay hydrated and eat independently. So again, working with your OT to find adaptive tools like utensils, hydration systems like I have pictured here. I have a couple guys with robotic arms to help them with eating, drinking. And again, you can put anything in a blender and puree it if that's what you need. So there's lots of options to eat healthy. A few other unique problems you may be having is one thing I see is needing assistance with feeding yourself. And this can be a difficult transition for patients. If you used to be able to eat independently, but now it's harder or you can't. So just learning to accept help from others with feeding, it can be difficult and can be an emotional transition. So to just take your time. It may take some time to work out problems. Maybe your caregivers love you and overfeed you, or maybe your caregivers get distracted and don't feed you enough. But just to give all of yourself some time and grace to work through those transitions, and you'll get to a new normal eventually. Constipation or slow GI motility can decrease appetite, so that can contribute to undereating. The goal is to have a soft form bowel movement every day, and any type of severe constipation or blockage can really cause stomach pain and decreased appetite. So I cannot emphasize enough the importance of working with GI if you need to, or your primary care provider or your muscle team, to be pooping every single day or maybe every other day. But so important for your overall health and good nutrition is to be pooping regularly. Many patients I work with can be self-conscious about being either overweight or underweight. So, maintaining a healthy weight can really help you feel good about yourself and is important for that reason too. Okay, so we had a lot of questions about prescription weight loss medications. So I have a little list here. There's some GLP-1 agonists and some other meds. It's probably not an exhaustive list because I feel like this area is changing so quickly. But I just briefly want to touch on this. These meds, as far as I know, have not been studied in patients with neuromuscular disease or young children. And so most of these, for the most part, are not even available to anyone under 12. And I think some of them have other age criteria. So each medicine has its own criteria for your age, your BMI, and do you have other things going on like diabetes or high cholesterol and things. So they're very specific, whether or not you even qualify to think about it. I do have some patients on the phentermine topiramate combo, and that's sort of one of the older meds that are being used. But the new GLP-1 meds, they do have some side effects and they can be expensive. So my concern as a dietitian are some of the side effects, including this list: loss of muscle mass, delayed gastric emptying, stomach pain, nausea, vomiting, diarrhea, constipation, gastroesophageal reflux or heartburn, decreased bone density, maybe associated with depression and dehydration. So this is not saying every patient will experience these, but these are some of the side effects that you could experience. And those are concerning to me because they are probably things you might already be struggling with without taking these medications. So just sort of adding on to some things you may already be dealing with. So my main recommendation is talk to your doctors. As dietitians, we really don't have much say or control over whether a patient is on one of these medications. So you really need to talk to your primary care provider. At our institution, it's our endocrinologists who are prescribing these. It really requires close follow-up and care under a doctor's guidance, not just the dietitian. And with that, I have some other considerations for these weight loss medications. These new GLP-1s really do have a powerful effect on decreasing appetite. So I can understand the appeal of these, especially if you're someone who is not able to walk and needs a wheelchair full time. So I understand, because it's a balance of intake and output. And if you're not able to exercise or burn a lot of calories, I understand the appeal for using these medications, and they are powerful. So the main effect is they really decrease your appetite and just cause you to eat a lot less food. But with that weight loss, you cannot really control the type of tissue that you're going to lose. So are you going to lose fat stores? Are you going to use muscle? Are you going to lose some of your bone density? I think those are the questions we don't really know. And for someone with limited muscle mass, we don't want you losing too much muscle. Or if the fat stores help you keep a healthy weight, we don't want your fat stores to become so low that if you get sick or need a surgery, that it's hard to recover from that. So those are some other questions I have. I've also seen where dramatic weight loss before a big surgery can be a problem. It's generally not recommended going into a big surgery, even if it's intentional to be losing a lot of weight. So for example, if you need to have a big spine surgery, spine fusion, I would consider holding off on starting these types of medications till after your surgery. And then lastly, I just want to say, despite taking the medication, your dietary behaviors are perhaps more important than the medicine. So really focusing on your food and drink choices and your eating patterns, because if you are taking this medicine and maybe you need to stop, you still need to have those healthy habits in place to keep the weight off. So now I just want to go through some resources and tools, that can help you specifically with weight management. If you do have a feeding tube, we can help you, with your weight goals. So it's important to work with a dietitian if you have a feeding tube and that's your main source of nutrition. Your dietitian can help you establish how many calories you need each day in order to achieve your goals. We can help you create a schedule that works for your schedule and helps you with your weight goals. Some families really like to make their own tube feedings, and you can do that with the healthy foods that you're eating as a family and blend them. It's a ton of work, but I have some families who, find joy in doing that. But there are a lot of commercially available formulas. I think a lot of people, maybe adults, get put on more standard kind of milk-based formulas, but there's so many options now, from milk-based to food-based, and more options now more than ever. So I really love to encourage the food. If you need to buy or have your insurance pay for tube feeding formulas, I love the food blends. Now, maybe they're not for everyone, because each person is different and it depends on how you tolerate things. But I always like to encourage the food-based formulas, and they can help you be healthy and achieve your weight goal with the help of a dietitian. Meal patterns are so important. So if you need to lose weight, a lot of patients I work with who are older, maybe mid to older 20s, young adults, oftentimes 2 meals a day is appropriate, either to maintain weight, or if you are eating 3 or 4 times a day, trying to eat twice a day if you need to lose weight. So for example, a lot of young adult patients I work with eat brunch and dinner, and that can be adequate either for maintaining their weight or trying to lose a little bit. I don't recommend meal skipping or intermittent fasting. I know this is popular, and honestly, eating brunch and dinner is kind of fits into that definition of intermittent fasting. But people with neuromuscular disease can sometimes be at risk for low blood sugar and electrolyte imbalances if you go too long without eating. So generally, I recommend regularly scheduled meals if you need snacks, but don't recommend meal skipping or intermittent fasting. If you do struggle with low blood sugar overnight, late night snacks are a good idea to try to prevent that. I recommend combining fiber-rich carbohydrates with proteins and fats. So a couple examples are Greek yogurt and fruit, peanut butter or cheese with an apple, or pretzels and vegetables with hummus. This slide is a lot of information. So hopefully if you have this and want to look back through it, you can. But I did put the reference here if you ever want to look up this study. It's just different types of ways you can eat healthy to help you achieve. Maybe you need lower blood glucose, maybe you have high cholesterol, maybe you have high blood pressure. So these are the different types of diets. This article talks about preventing diabetes. So just different ways that you can decrease your risk for heart disease and diabetes by eating these types of diets. So the first one I have circled in green at the top is what we'd consider just a regular healthy diet. There's nothing too special about it, but choosing fruits, vegetables, lean meats, healthy oils with, avoiding or trying to limit added sugars and salt. The next is the Mediterranean style diet. I actually try to kind of follow this type of diet myself, where you're just eating plant-based foods, using olive oil, low-fat dairy products, like some eggs, if you're an adult, a little bit of red wine here or there, things like that. The next types are a vegetarian or vegan diet. This has been shown to reduce risk of diabetes, help you lose weight, lower cholesterol. Vegetarian's a little bit easier to follow. I would highly recommend if you'd like to eat a vegan diet, just meeting with a dietitian to make sure, you have your protein and vitamins and minerals covered in your foods, and you might need some supplements. Other ways to eat healthy are low fat or very low fat diets. These are kind of a little more old school, like 80s, 90s, but they do have some research showing it can reduce risk of chronic disease. More popular now are these low carbohydrate or very low carbohydrate diets. And there's some good research showing this can help you be healthy. So those are things where you're really cutting back on those carbohydrate rich foods, cutting back on added sugars, focusing on lean proteins and vegetables. There's a special diet if you have high blood pressure called DASH. And then a little bit older too is the paleo diet, where you're really just trying to eat things like game meat and berries and nuts and vegetables, but really avoiding those refined sugars, fats, and things. So all this to say, there's a lot of options if just based on what kind of diet you want to follow and how your family eats or what family traditions you have. There's a lot of different ways you can eat healthy, and there's not one right answer. If you need to gain weight, for kids, we don't worry so much about heart healthy things. You can, add those creams and butters, but if you're older and want to eat heart healthy, we want you to use heart healthy oils. Dairy foods can add calories if you can tolerate or aren't allergic to dairy foods. Lean meats, nuts and seeds can add calories. If you have a hard time chewing those, you can do flaxseed meal, chia seeds, nut butters, things like that. Dips can add calories with hummus, avocado, guacamole, things like that. You can make homemade smoothies or shakes. There are medical oral nutrition supplements. Again, so many options, too many to go through, but whatever you're looking for, whether it's milk-based or plant-based, a dietitian can help you find what you need and get it ordered through home care. Here's some resources for meal planning. There's a lot of apps out there, and I'm sure you could pick an app and it would be fine. But I just wanted to highlight the myplate.gov website. In order to do this, you need to find out from a dietitian what your calorie needs are. But you can get a plan specific for you. And I just want to highlight your calorie needs are not going to fit in this chart with this age group. So that's why you need to talk to a dietitian. So maybe you only need 1,000 calories a day. And on this chart, that means that's for a 2 or 3 year old. But as an adult with neuromuscular disease, you might need 1,000 calories a day or less. So you can choose the calories you need. And this is an example of a 1,400 calorie plan, and it can actually help you go through. You can write down, it has the goals for the day, and you can write down exactly what you ate and whether or not you achieved your goal. So these are some things you could go to this website and print out, and it could help you manage your daily intake. I have resources for healthy recipes here. The myplate.gov website has recipes. Eatingwell.com has a lot of recipes. That used to be Cooking Light. The American Heart Association and the American Diabetes Associations have recipes as well. And then if you are looking if you do not have a registered dietitian associated with your neuromuscular multidisciplinary clinic, you can find one separately. So this is the website for the Academy of Nutrition and Dietetics. The web address is eatright.org. You can see that over here, eatright.org. And then it'll allow you to click on this red button to find a nutrition expert, and you can choose in-person or telehealth. You can enter your zip code or your city where you live, and it will give you a list of people who can help, who are registered dietitian nutritionists. And I do want to emphasize the registered dietitian part. Any nutritionist in a hospital has to be a registered dietitian. There are other nutritionists out there that are more like functional medicine, holistic, naturopathic medicine, which is a different type of nutritionist. So those are nutritionists. You always want to look for that word registered dietitian for looking for someone who can help you with neuromuscular disease. And then, as I mentioned before, these are resources for how to calculate your BMI. Again, taking that with a grain of salt. How useful is this? You know, but we can track it over time. So on the CDC website, if you just kind of Google BMI for adults and kids, you can plug in your numbers, your height and weight for an adult, and it'll tell you what your BMI is. And then for kids, their age, height, weight, and boy or girl, and that will give you those numbers. But again, your doctors will have these numbers for you too. And then adaptive activity, just highly recommend. There's so many benefits for mental health and weight and just having fun. So these are some ideas local to Colorado, but I'm sure wherever you're from, you have options in your areas. But things like adaptive adventures, we have National Sports Center for the Disabled that'll get you up on the ski slopes if you want to do that. Children's Hospital Colorado has an adaptive rec department. But I did find the MDA also does have a guide for getting involved in adaptive sports on their website, which has some great ideas to help you get your bodies moving as best you can. And that's what I have today.
Thank you so much, Laura. That was full of great information. I will take over the screen here so that we can move into our Q&A section of the presentation. And we had a lot of questions submitted upon registration, as I shared with you earlier. So I'm going to try to mix in. We had a great amount of commentary in the chat and questions. So we hope that everyone who joined us live found some great resources. But I'm going to try to mix these in here. So we're going to start with a question. You talked about the GLP-1s. So where can we find any current or future studies on GLP-1s and neuromuscular disease?
That is a great question. So you can, I guess the best place would be to go to your neuromuscular multidisc clinic and ask the doctors if they've found any specific research. You can, if you have access to PubMed and you can really just Google, the keywords GLP-1s and neuromuscular disease and research. And so I did that, this week, and there was, nothing popped up. So, but
it's
yeah,
all very new. Yep, it's all very new. So we understand. But no, that sounds like the route to take right now. So thank you very much. Um, my son is taking corticosteroids. What is the best way to manage his weight? Are there other recommendations for those on corticosteroids, or are the recommendations the same?
The recommendations are essentially the same. If your son has Duchenne, there's really distinct transition times with Duchenne where weight is more of a concern. So really that time where they may be on the corticosteroids but losing ambulation, it's a really easy time for all my patients to gain a little too much weight. And so you're not alone, but these general principles definitely apply for that situation. But it's hard because their appetite is up, their mobility is going down, and they're at an age where it's a little bit hard to understand how it's all interrelated with their appetite and intake. But yes, the same general principles apply.
Thank you so much. Um, Someone asked, are dietitians for muscular dystrophy covered by insurance?
They should be. So as far as I am aware, whether my patients have Medicaid, Medicare, or private insurance, as when I bill as part of a neuromuscular clinic, it is well covered. So every once in a while, we'll get a flag that for whatever reason, I'm not covered. But in general, I would say yes.
Great, thank you. Um, what should I, or sorry, when should I make the decision to switch from eating when swallowing becomes hard and I really like food and do not want to give it up?
So that is a really great question, and it's a difficult and emotional process to go through. One of the things we've been doing here is connecting our patients and families with palliative care. So that's different than hospice. Palliative care can help you anytime along your journey, like even right at diagnosis. And a palliative care provider can sort of help you define for yourself what you do and don't want. Do I want artificial nutrition? Do I not? And can help you kind of frame those decisions in ways that you feel good about and ways that can support your medical team in helping you. But oftentimes we just talk in general when eating becomes more stressful than pleasurable, it might be time to think about using a feeding tube. And a lot of times patients are relieved after they get one. It just reduces some of the pressure around eating. And then you can also decide, even despite maybe having a swallow study showing some difficulty, you can decide with palliative care that, hey, I really love eating this thing or something, or so often I like to have something by mouth. And you can just try to, make a plan that works best for you. But just, involve your team and your family, and I'll try to help you get through that difficult decision.
Absolutely. In the chat, there was a lot of talk about different snack ideas and meal ideas. There was a question about the best ideas for desserts for those who can't exercise to burn calories.
Yeah, so dessert can be fun, but it is typically sort of high calorie, high sugar, maybe high fat. So, fruit can be, if you kind of reframe some ideas, fruit can be a good snack, or like all fruit frozen popsicle type thing, or sorbet. Maybe some dark chocolate or milk chocolate. And again, maybe there's just some dessert you absolutely love and want to have. And so just try to enjoy it in really small quantities. So because we want you to continue to enjoy eating. We don't want it to feel too restrictive or too much of a chore. We want to preserve the enjoyment of eating too.
Yes, it's all about that portion size you talked about. Let me see here. So I want to respect everyone's time, but I'll try to go through a couple more questions. How do you best handle weight gain due to medication?
So that kind of goes back to that other corticosteroid question. It's these same principles apply. So if you know you're going to be starting a medication that causes weight gain, just really sort of paying attention to the decreasing your calorie intake through portion sizes and food choices and what you're drinking. But medications in either direction can have a really powerful impact on your appetite. So yeah, just sitting with a dietitian maybe and coming up with ways to decrease your intake.
All right, sounds good. If one is wheelchair bound, how do you weigh yourself if you can't get up to stand on the weighing scale?
That is a great question. So at our clinic, we have a special wheelchair scale. It's built into the floor. So what we have patients do is wheel onto the wheelchair scale, sitting in their chair, and take a weight of the patient and the chair together. And then we have a Hoyer lift in our clinic intake room, and then we're able to take you out of your chair and weigh the chair by itself. So then you can subtract the chair weight from the total weight. And then that gets tricky over time because people's chairs change or you get a new part. And even though it's the same part, it weighs different. So it's tricky over time. Sometimes we have, if you're smaller or a child, a parent can stand holding the person and weigh the patient and the parent together and then weigh just the parent. Similar idea, but that only works for so long till you get too big. But yeah, so a lot of primary care offices don't have these special scales. So maybe really trying to find that a neuromuscular clinic. I've also had people get creative at home. You can put a scale on your Hoyer lift. So if you're ever in your Hoyer at home, for whatever reason, you can weigh yourself in your Hoyer lift. I've had other families get really creative, like if they live on a farm or ranch with some green scales and things. But I would hope there's a clinic in your area with a wheelchair scale.
Great, thanks. And I think that we did link our care center finder in the chat at the beginning, but we can probably put that in there again in case someone wants to find one of our MDA care centers. And then I'll wrap it up with this question. What if you can't gain weight no matter what you eat?
Yeah, so that patient's chart I showed you where it really flattened out. So I find that there are certain neuromuscular diagnoses that really involve the decrease, like a significant impairment in muscle mass. So there are some patients that we work with my doctors that we've really struggled. We've tried everything, even sometimes feeding tubes, aren't the answer. So there's certain specific diagnoses that make it very, very difficult to gain weight. So we usually try, along with the doctors and myself, just try to make good notes in our chart that because of your muscular dystrophy, it's very difficult to put on weight. So it just depends on the situation, but that can happen sometimes.
All right. Well, Laura, thank you so much. I'm sure we could keep you here all day, but we're going to respect everyone's time. And I'm going to go ahead and conclude the webinar. But thank you for sharing your time and expertise with us. Any final words before I move forward?
No, thank you for having me, and it was an honor. Appreciate it.
Thank you so much. All right. Thank you so much to everyone who's still with us. This year marks MDA's 75th anniversary. This milestone has been made possible by generations of dedicated support from people living with neuromuscular disease, their families, researchers, clinicians, volunteers, and donors who boldly drove our mission forward. As we look ahead, we remain committed to honoring this legacy, building on the impact we've made together, and continuing our momentum toward transformative progress for people living with neuromuscular disorders. To learn more, visit mda75.org. We again invite you to join the MDA community. Joining is free and will help you stay up to date on all of our programs as well as the latest research. Please scan the QR code with your smartphone or visit the link in the chat. Before we go, I want to be sure to notify you of MDA's current and upcoming programming to help you stay connected to the MDA community. First, I want to highlight the new MDA Durable Medical Equipment Grant Program. The grant is available for those living with neuromuscular disease and covered by the MDA umbrella. For more information on eligibility and where to apply, click the link in the chat. Next, MDA has upcoming webinars on updates in research and care, vaccines and neuromuscular conditions, safety, science, and guidance, which will take place on October 8th, and Home Solutions for Greater Independence on October 28th. Registration is free, and if you register for a program and can't make it on the day of, you will be emailed the recordings to your inbox. You can learn more about each of these programs by clicking the link in the chat. We again would like to thank Laura Watne for sharing her time and expertise with us today, and we want to hear from you. What did you like about today's program and what can we do better in the future? Please fill out the brief survey that will pop up right after this webinar, and your feedback is very important to us. If you have any questions or are looking for support or resources, please contact MDA's Resource Center at 1-833-275-6321 or via email at resourcecenter@mdausa.org. That concludes today's program, and we hope to see you again in the future. Thank you very much, everyone.